So Dr. Maxwell did a great job setting up lots of the ideas that I'm going to talk about. I was asked specifically to talk about gastrointestinal dysfunction in POTS, but as Dr. Maxwell's lecture kind of sets the stage, this is really complex and it's difficult to talk about this in isolation. Here are my disclosures. Really, the most important one is that right now in the United States, there are currently no FDA-approved therapeutics in this clinical space. So everything that I'm going to talk about are coming from clinical expertise that I've gained over the years of caring for patients with gastrointestinal complications of autonomic disorders. And really, I want to set the stage and really kind of drive home the point that gastrointestinal dysfunction is part of POTS. Like, it's not a consequence in my mind. I feel like the term POTS really kind of, it doesn't adequately capture all of the physiological changes that happen when you have this type of autonomic disorder. And what I'll show you by giving a brief neuroanatomy introduction is why I think this is really just part of POTS rather than like a complication of it. I think it's just sort of not thought about in the right way. And I'll use this diagram to sort of drive that home. So this is really just a really simplified innervation pattern for the autonomic nervous system. And what you can see is the autonomic nervous system is innervating all the different components of the gastrointestinal tract, along with, all other components of our body, including sweat glands or blood vessels, obviously our heart, and that's where POTS, kind of gets its name from, but there are a lot of other components that can go wrong when we have an autonomic nervous system disorder, whether it be POTS or some other. And so some other key concepts that I would like us to focus on is really that the nervous system, immune system, and endocrine systems are playing integral roles in maintaining physiological homeostasis. And within tissues, neurons, immune and endocrine cells are in close physical proximity. And the reason this becomes important is because it has implications for when an individual has a connective tissue disorder, and whether it's a primary connective tissue disorder or a secondary connective tissue disorder, when you have a disruption in our connective tissue, it's actually going to impact these interactions with our nervous, immune, and endocrine cells. And then the other thing is that there's bidirectional communication between neurons, immune, and endocrine cells. And so this is why I start to talk about something called the neuroimmune axis. And so some of the symptoms that are driven by disturbances in the neuroimmune axis are, all these GI symptoms that a lot of people encounter, like nausea, headache. You can even get cognitive changes, rhinorrhea. You can get oral tingling or burning. You can get a dry mouth. You can have difficulty swallowing. You can have just kind of unrelenting belching. You can have abdominal pain, bloating, a sensation of early fullness. You can have changes in your bowel habits. And then you can have the adverse reactions to foods, flushing, urticaria, or rash, which can be driven by kind of these neuroimmunological processes, and whether it's primarily mast cell or some other feature has yet to be determined for most people. And so one of the things that I like to emphasize is that the role the neurogastroenterologist can play in diagnosing and managing autonomic nervous system disorders is actually really important. However, I have to emphasize that most gastroenterologists aren't up for the task. And so by having conferences like this, you're raising awareness, and I think pushing your gastroenterologist to kind of be a better partner with you and your other clinicians, because there is actually a lot that we can offer for diagnosis and for management of these neuroimmune axis disorders. And so really the first step in management is actually understanding what the diagnosis is. And this is going to help us select therapies or other interventions that are going to make you feel better. And so in order to kind of get to that portion of my talk, what I first want to do is define the neuroimmune axis. And so I'm just going to start with a cross section through the small intestine. And so this is showing you all the layers of the tube that is comprised of the small intestine. And so you have outer muscle layers, you have inner muscle layers, and you have a lot of connective tissue, and then you have these villi that increase the surface area of the gastrointestinal tract, which is very important for increasing absorptive capacity. And then you have the inside or lumen of the gastrointestinal tract. And this is important to remember that this is actually outside the body. And so you have microbes, you have food traversing through here, and these are really outside the body. So you're exposed along your largest mucosal surface to the outside world. And so because of that, you have to have a different type of immune system so that it's not reacting to everything that it's coming in contact with, and it's able to kind of selectively react to things. These reactions are controlled a lot or mediated a lot by our nervous system. And so when you have disruption in the part of the nervous system that is controlling barrier function and immune reactions, such as when you have an autonomic nervous system disorder, there's a lot that can go wrong in the gastrointestinal tract. And so this is just to drive home a piece, and this is more towards helping you talk to your gastroenterologist, because when you tell them that you have an autonomic nervous system disorder such as POTS, many of them are not going to know what to do with that information. But one of the things you can help them understand is the enteric nervous system, which is a specialized part of the nervous system, is actually a part of the autonomic nervous system. And so this is how you can help them understand that this is really relevant when they're thinking about what is the cause of your gastrointestinal symptoms. And the way that this specialized enteric nervous system is arranged along the length of the tube of the gastrointestinal tract is in a mesh-like network. And so this mesh-like network is controlling a lot of things, including motility, barrier function, timing of release of endocrine components, and digestive enzymes and things like that. And so when there's a disruption in the function of your autonomic nervous system, all these processes can actually be dysregulated. And so then if we just quickly talk about all the things that the gastrointestinal tract is supposed to accomplish, you know, the two things I think we think about are really nutrient absorption from our diet and water absorption. But it has to do a lot of things to be able to even absorb the nutrients from our diet. So it has to process all the food that we chew and that enters our stomach. And then we have to actually break down those foods into smaller molecules that can be absorbed across that barrier. And then we have to control for like waste storage. So that's what the colon does. There'll be some more water absorption there, and then stool formation and timing of bowel movements. And so all this is controlled by your autonomic nervous system. So again, it's not surprising if you have a disorder of the autonomic nervous system, any or all of these functions can actually be impacted. And the severity of these can actually fluctuate with the severity of the dysfunction of your autonomic nervous system. But the really important thing that the gastrointestinal tract does besides nutrient and water absorption is actually mucosal barrier regulation. And this is, again, because it has to regulate, it has to balance sort of that interaction with the outside world so we can absorb nutrients and water, but also not overstimulate our immune system. But so much of our immune system is actually trained in the gut, and it's in the small intestine that this primarily occurs. And this is where that neuroimmune axis communication, that interface, is happening in real time at tissue level. And this is just to give you a little bit more of an example of something that's very, very detailed. But really the point of this is these are incredibly complex systems, and we can't simplify how we think about these to, describing just like bacterial overgrowth. There's a lot of other things that actually can happen here. And so the point that I want to make with this slide is that we have not only components of the vagus nerve innervating all the way to the level of the gastrointestinal tract, but it's other components of the sympathetic nervous system that are directly innervating components of the enteric nervous system, such as the myenteric plexus or the submucosal plexus. But then they're also directly innervating immune cells, this epithelial layer here. So they're regulating barrier function. So I don't call this leaky gut. I actually call this impaired barrier function. So this is really important. So when you have impairments in barrier function, you're at greater risk for immune activation. It's also directly controlling cells that produce this protective mucin layer that protects the epithelial layer from the outside world. There's just a lot going on here, and it's really important that we understand it in its entirety, because any change we make to the system can have both local and systemic, including central nervous system impacts. And so I'm just going to give you a couple of examples of the neuroimmune axis in action. And so this is one. So this is where it's actually regulating luminal sampling. And so this is through regulation of that barrier function. So in order for us to know, like our immune system to know sort of what's in the lumen of the gastrointestinal tract, they have to take components of the fluid and molecules that exist within the lumen and bring it into our tissues and then kind of expose it to our immune cells. And so this is actually regulated by cholinergic neurons of our autonomic nervous system. And so again, really just to drive home the point further is that when we have disruption in the functions of our autonomic nervous system, this process is dysregulated. And so you get impaired intestinal barrier function, or quote unquote leaky gut. And so then you can have increased activation of different types of immune cells. And so what here we're seeing is dendritic cells and T cells, but there's also a lot of other types of cells in the tissue, including macrophages, eosinophils, mast cells, other types of lymphocytes that can be kind of activated continuously if you have an impairment in barrier function. And so then this is another example. So this is, we have our enteric neurons. So this is our specialized nervous system of the gastrointestinal tract. So they're over here in purple. And so they release a compound called colony stimulating factor. This is recognized by muscularis macrophages, which are a type of resident immune cell that lives within the tissue of the gastrointestinal tract. And this CSF1 actually leads to survival of these macrophages. And in turn, the macrophages produce BMP2, which you don't have to remember the name of it, but what it does is it's a signaling molecule recognized by these enteric neurons, and in this way is actually controlling motility. So you have immune-driven regulation of gastrointestinal motility. So where could this go wrong? So again, now we have, these are sympathetic neurons, so not part of the autonomic nervous system, but the ones that are coming from like our celiac plexus, innervating all the way into the tissue of the gut. They actually release norepinephrine, which is recognized by muscularis macrophages. And then again, the macrophages are releasing like polyamine compounds that help the neurons within the gastrointestinal tract survive. In infection, you can actually have disruption of this. And so you have a disruption in the norepinephrine signaling, you have a reduction in these polyamines, and you can actually get a neuron cell death due to infection. And the reason I show this example is it's really important that there are a lot of conditions, particularly autonomic nervous system disorders, that seem to arise after what I think is an immune activating event, which can include infections. They can be bacterial, they can be viral, they can be fungal, but there also can be other immune activating events that can contribute to this. And so it's really important to think about the onset of your symptoms and what might be going on, because no matter what medicines I give you, if you have loss of neurons in your gastrointestinal tract, I'm not going to be able to expect for you to get better. So then we have to figure out, can we actually target the immune system to kind of stop the drivers of the destruction of these neurons? So then this is just another example, again, with neurons communicating with mast cells this time. And so the neurons can directly release neurotransmitters or neuropeptides, and they can lead to mast cell activation or degranulation. And then the mast cells, in turn, can release histamine, serotonin, tryptase, but a whole slew of other mediators that then the neurons can actually, they have receptors to recognize, and you can kind of start to stimulate this feed-forward cycle where you have continuous activation of neurons that then are releasing substances that are activating mast cells, which then are degranulating. And as Dr. Maxwell mentioned, those mast cells are also releasing peptides that are further breaking down the connective tissue within the tissues that this is happening. And so you can get those secondary connective tissue disorders because of processes like this. And so it's really important to understand this and try to stop this. And then this is just another example, again, of these neuroimmunological interactions driving host inflammation in response to infections or other types of stressful events. And so these neuroimmune interactions can either upregulate pro-inflammatory components or downregulate them. And so you really do need a well-functioning nervous system to be able to properly regulate these neuroimmune interactions. And so then I'm going to switch gears a little bit and just add in this piece about the microbiota, because it's really important, because our microbiota is communicating with our nervous, immune, and endocrine systems at the level of the gastrointestinal tract. And that's why this level of communication is really important to understand, because if we do anything to alter the microbiota, we actually can be impacting all of these other systems. So we have to actually be very, very thoughtful when we consider interventions that alter the microbiota. And so the microbiota neuroimmune axis, so this is really just talking about the ways that this microbial communication occurs, is that the microbes can secrete substances that can enter the blood and travel all the way to the central nervous system. And so this is why sometimes with eating, you can get, among other reasons, you can get like central symptoms like fatigue or cognitive impairment or cognitive changes. And so you kind of have to be thoughtful about that. Microbes can also activate endocrine cells or neuropods. And so these are relatively recently discovered endocrine cells that synapse directly with the enteric nervous system, which then is synapsing with the autonomic nervous system, the extrinsic part of it, and then communicating directly with the CNS. So again, you're having both local, distant effects from this type of signaling. Microbes can also activate other enteroendocrine cells, which then are releasing hormones that can, again, have both local and distant effects. And then microbes can influence immune function and inflammation, and this can all have implications for the enteric nervous system specifically, and then the extrinsic autonomic nervous system and the central nervous system. So again, we have to be really thoughtful when we're thinking about altering the microbiota. And again, I'm just going to show this slide because it's really important for this neuroimmune axis communication. And so while a number of our patients have small intestinal bacterial overgrowth, I think it's more a signal of something that's wrong rather than something that necessarily needs to be treated with the antibiotics, because I think that antibiotic therapy can have long-term complications that we're not quite aware of. The other point that I'm going to make about the microbiota is that I do see this trend where lots of patients are being sent to get stool testing to assess their microbiome or microbiota. These are not proven tests. So when they're giving you results, we actually don't know what's normal. And if you are getting any sort of microbiota assessment, it more correctly should be done from the small intestine. But those tests don't exist yet. And so I would save your money if someone's suggesting that you get any stool test done to assess the microbiota. Of course, there are other clinical indications when we would do stool tests, such as investigating for malabsorption or true pathogenic microbes. And so really what I want to emphasize is that if we think about gastrointestinal disorders as part of these microbiota neuroimmune access conditions, we really have to rethink the traditional mechanisms of gastrointestinal disorders. And what I mean by this is we classically will think about mucosal disorders. So some of our inflammatory bowel diseases, things like that, where you have a specific injury. We also see things like mast cell activation syndrome. Some of the eosinophilic disorders fall into this range. But again, these immune cells, when they're infiltrating the mucosal layer, they're not there in isolation. They're, again, interacting with the nervous system, other components of our immune system and our endocrine system that can have, again, local and distant effects. So we have to think about it in a larger picture. The other piece that I think very frustrating for patients is that if you go see a gastroenterologist with symptoms related to autonomic nervous system dysfunction, they'll rule out the basic stuff. They'll look for inflammatory bowel disease or celiac disease, and maybe they'll look for immune deficiencies. But then if they don't see anything obvious, they're going to tell you all your tests were normal and there's nothing wrong with you. But that's not true. That's actually not helpful to you, and it's not helpful to your referring providers. And then there's just some more complexity around microbiota disturbances, and I think we have to be thoughtful about that moving forward. And then again, motility disorders, again, they're not happening in isolation. And I'll just give you a couple of examples of sort of how I think about this clinically. So traditional diagnostic tools, like everybody gets an endoscopy if they come in with gastrointestinal complaints, but they really don't do much. They take uninspired biopsies. They don't do very interesting stains. It's actually really hard for patients in this clinical space to even get their gastroenterologist to order mucosal mast cell staining. And it really can be helpful to understand if there's a mast cell component to your gastrointestinal symptoms. And then they do motility tests, and I'll show you an example in a few slides about how there's a lot of limitations there. And then you can do laboratory and stool studies, breath testing again for SIBO, and then imaging. And while these can all serve as components to a really thorough evaluation, until we start to put them into context of microbiota neuroimmune access disorders, especially in someone who has an autonomic nervous system disorder, we're not really understanding the true complexity and I think creating appropriate pathways for helpful therapeutic interventions. And so I propose that thinking about this more in this sort of neuroimmune access framework is more like a systems biology way of thinking about really complex conditions. And I think everyone who's living with an autonomic nervous system disorder recognizes the complexity of these conditions. And we're arrogant to think if we can just simplify it down to simple individual components without thinking about the bigger picture. And I think when we start to reframe it, this is going to help us accelerate research in clinical care, but it's also going to take next generation tools for us to do this. And I'm going to give you a couple of examples of the tools that already exist that can really help people with gastrointestinal symptoms and autonomic conditions. And so specialist referral is required. And one of the things I think that I always feel bad about is when people ask me, well, what can I do? Or what can my primary care doctor do? A lot of times, not much, just sort of recognize that there's something going on and then get you to the right specialist. And so this is a case of a young woman who had profound abdominal pain, nausea, vomiting, and essentially like all food intolerances. So everything she ate, she would either vomit up or she couldn't even get it down. And she was losing so much weight, she was requiring nutrition by IV, and she was hospitalized. And I was called because the doctors there didn't believe that she needed to be fed by IV because they had done a particular type of motility test called a gastric emptying study, and they reported that it was normal. But her symptoms were so profound. So I had her come out to see me. And we got this test called the Smart Pill Wireless Motility Capsule. And so it's that blue little capsule you see down at the right-hand corner of the screen. You swallow it after eating a standardized meal, and then you wear a recorder for up to 5 days. And the blue line at the top helps us understand when the capsule is ingested and when it exits the body, because it's measuring temperature. The green line here is pH, and so this helps us understand where in the gastrointestinal tract the capsule is. So we all know that the stomach is the lowest pH environment within the entire gastrointestinal tract. So scrunch right up here at the beginning is the time that it's spent in the in the stomach. And then you see this abrupt rise in the small intestine. It continues to rise, and then you see this abrupt drop off when it's in the colon. And then the rest of the time is spent in the colon. The red lines at the bottom are basically pressure measurements. So the higher the bar, the greater the pressure on the capsule as it moves through the gastrointestinal tract. And this is really just a measurement of the strength of contractions as the capsule moves through the gastrointestinal tract. But really, so for this young woman, her gastric emptying time was actually on the fast side, but her small intestinal transit time was nearly 16 hours when the upper limits of normal is 6.5 hours. And then her colonic, I apologize. Her colonic transit time was nearly 150 hours when it should be around 60 hours. And so she met criteria for intestinal failure. And so this is the first part in management. This is validating what the patient is experiencing with objective data. So now no one can argue that she does not require to be fed by IV. But what this test doesn't do is it doesn't tell us why she has this. And so we have to start looking beyond that so that we can intervene and maybe change the course for her. And so there's other types of tools that we can use beyond just using like mucosal biopsies that we would look at to look for like mast cells in the kind of like epithelial and submucosal layers of the gastrointestinal tract. This type of biopsy technique allows us to get all the layers of the gastrointestinal tract wall. And so in an individual like that young woman, what I would want to do is sample from the small intestine where she has such profound delays, right? So she has really significant dysfunction there. And what I would want to do is understand, does she have an injury to the myenteric or submucosal plexus? Are there injury to the small nerve fibers? Is there immune infiltration into some of these areas? Because this is going to allow me to select a therapeutic that may target some of that dysfunction. And so what you can do once you get that full thickness biopsy, which is what they're referred to, is we can start to do kind of mapping of, remember I talked about that mesh network. We can map like a discrete area of that mesh network. We can start to look for immune infiltration and start to understand better kind of what we're up against. Like, is there really significant neuron loss? Is there a targetable immune signal that would allow us to apply like an immune modulatory therapeutic that might reverse this process so that we could actually get her gastrointestinal tract working better? And this is an example, not from that patient, but from published series looking at people with idiopathic chronic intestinal pseudoobstruction, which is essentially intestinal failure. And what you can see, this is a full thickness biopsy from the small intestine. And so stained here in the control panel is the myenteric plexus. And so you can see it stains very boldly brown. In the case, so for the individual that had intestinal failure, you can see that there's really significant neuron loss, right? So this is an injury to the myenteric plexus. And interestingly, what you can see in these bottom panels, in the controls, they stained for mast cells. And you can see that at this deep tissue layer around the myenteric plexus, which is no longer stained because they've stained for mast cells in this section, you don't see any mast cells there. But in the cases where the myenteric plexus is supposed to be, you start to see this infiltration of mast cells. And this panel E is just higher power. They also stained for eosinophils and other types of lymphocytes, and they found really significant immune infiltration into these areas. What we don't know is the natural history of this. Is this a cause or consequence, but these are the things we have to start to understand if we want to be able to help our patients get better that have profound motility disorders. So getting to the correct diagnosis really is going to help us because it's going to allow us to select therapies. And so what I want to highlight is that motility tells us that something's wrong, but it doesn't tell us why it's wrong. So we actually have to do the next level of testing. Tissue sampling, we can have them do more than just a standard H&E stain. We can have them do more than mast cell staining or eosinophil staining. We can actually start to look at nerve density, nerve fiber injury, and deep immune profiling. And if we get this information, this is going to allow us to select an appropriate therapeutic intervention. So then case 2 is really around abdominal pain and kind of multiple food intolerances. And I know irritable bowel syndrome is classified as one of those functional gastrointestinal disorders, which have now been reclassified as disorders of the gut-brain interaction. But irritable bowel syndrome, for the data that we have, affect a huge proportion of the world's population at large. And many patients with autonomic nervous system disorders are incorrectly diagnosed with IBS. But I just want to make a point with this case. So half of people predicted to have irritable bowel syndrome actually have a non-IgE mediated allergy. And there are emerging diagnostic tools that we can use during endoscopy to help us discover that. And so this is a really cool test. It's called confocal laser endomicroscopy, or CLE. And it's done during routine endoscopy. And so that means that when you come in for like a routine upper endoscopy, we can actually just give you a contrast agent by IV called fluorescein. And what that does is, remember that single epithelial layer that I showed you that kind of lines that the inside of the lumen of the gastrointestinal tract? What it does is it highlights these individual cells here. Here's one with a significant amount of fluorescein at the tip. And then this is the lumen of the gastrointestinal tract. So what you can see is this person has an intact barrier because you're not having leakage of fluorescein just at baseline. And so then what they were able to do is select an antigen. So it could be a food, an excipient in medication, or anything that you're reacting to. And we can test in real time whether this causes an injury to that epithelial layer. So it's directly impairing that epithelial barrier function. And so in a matter of minutes, what can happen is that fluorescein is leaked out of these cells because there's a direct injury to the cell. And so this is a non-IgE mediated process, which means that we can't pick it up with skin prick testing or blood testing. And so this is just further time lapse where you're just seeing more fluorescein leak. So this technology in real time allows us to determine what components of your diet, so particular foods, what food additives, what food preservatives, excipients and medications you may be reacting to. So instead of giving you a diet that says, oh, let's just guess and have you eliminate all these different foods, we can actually test it in real time. So we know exactly what you're reacting to, and we're having you eliminate that specifically. And what the studies have shown is that it leads to better compliance. And so in this particular population where they looked at irritable bowel syndrome, 70% actually tested positive for non-IgE mediated allergy. And it's probably going to continue to increase over time because we're in general just seeing a lot more immunological disorders arising, very likely because of ultra-processed foods and environmental toxins. But it also at baseline can detect alterations in mucosal barrier function, which would be missed by standard histological techniques from biopsies. And they are showing that it detects eosinophilic activation. Well, we're going to look to see if it can actually detect mast cell activation as well. And I would be surprised if it didn't, because mast cells we know are involved in both IgE and non-IgE mediated allergies. And so I really just want to sort of end with improving the diagnosis, through discovering the mechanism of dysfunction, is going to truly expand our therapeutic options and really move us beyond just symptomatic management. And so in summary, anyone who has an autonomic nervous system disorder, it's super common to have gastrointestinal symptoms. It's also common to have these change over time, fluctuate over time. And so really don't be discouraged if you got a test and it was quote unquote normal, but your symptoms are way worse. A lot of times it does mean that you do need to be retested. And then the other thing that I'd like to encourage everyone to do is kind of think about this in a different way and think about like the microbiota neuroimmune axis, because it allows us to really start to think about the complexity of these conditions and why we have to talk about neurological disorders, immunological disorders, endocrine disorders, connective tissue disorders when we start to talk about conditions like POTS. And so that's why I think like POTS is an oversimplification of what can happen in these conditions, and especially for people who are living with them. And then in conclusion, I really just think that gastroenterologists, and particularly neurogastroenterologists, can really be great patient partners, because we have a lot of the technologies that are going to allow us to improve diagnostics and then be really smart about selecting therapeutics that will be able to treat these disorders. And so those are just some references, but thank you so much for your attention.